Okay, so we have heard much meat has been thrown into the water, and so now we can kind of have a chance to dissect it. And in order to do this, what I'd ask the panelists to do is to just briefly introduce yourselves and perhaps give a little bit of background on your orientation to these questions. And then we'll come back to some questions that have been hopefully shared with you that we'll run through with your participation. And then as we finish that process, we'll open it up to anybody who has additional concerns, questions, or comments, okay? So, Dr. Stillman, do you want to start?
Surely. So I'm Arthur Stillman. I'm Emory University, a radiologist, cardiothoracic radiologist. I've participated in lung cancer screening for many years, coronary calcium screening for many years, and I've published on these topics.
Yeah, hello everyone. I'm Sean Fain. I'm a medical physicist at University of Iowa. I've worked on standardization of CT protocols for lung cancer screening. I worked with the Quantitative Imaging Biomarker Alliance also on lung density quantification for emphysema detection.
Hello, my name is Sebastian Schmidt, a medical doctor from Germany. I work for Siemens Healthineers as head of medical affairs, computer tomography, and in this role work on establishing lung cancer screening globally for more than 12 years now. Of these 12 years I was in discussion with the German authorities about the lung screening program in Germany that starts next April.
And good afternoon from my side. My name is Liebenberg. I'm a physician scientist, chief medical officer of I-ELCAP, small diagnostics company. We develop risk markers in the area of lung cancer screening. With regard to my history, I left the clinic behind 20 years ago, entered the world of biomarkers, and since then have implemented products in this space, starting very early with cell-free DNA, and now looking at systems biology and metabolomics as the main source of information.
So thank you all. And just to set a little bit of the stage, we're talking about the big three. And it turns out that the big three are very diverse in terms of their analytical implications. And the data that we've heard about mostly today has been about initiating screening. And one of the most important things that we think we're going to derive from this is once screening is established and people are coming back year after year and they're aging, there's an opportunity to look at change over time, which across all three of these disease domains will perhaps be the most informative parameter to the clinician. Is the disease process getting better? Is it stable? Or is it worse? And to do that in a way that isolates measurement noise, which is much bigger than anybody wants to talk about, is a problem. And so we've been kind of thinking about how to approach this more systematically so that we can focus on the biology of change over time as opposed to the measurement noise over time. So against that backdrop, Professor Oudkerk, I think, has a number of questions that he wants to kind of talk. And I would ask, are these questions now, or are these questions as we start looking at these these annual returning populations that can focus on change analysis in a digital world?
Okay. Now, yeah, the first thing I would like to address is the things of definition. So we have the very adequate presentation, last presentation of Professor Sayo. But the problem is that we measure not COPD. We measure emphysema, and data are in the data set, of course, which reflect denominators of COPD indeed, but it will be very cumbersome to use those data. And often also in most acquisition systems that we use, the data are insufficient to, for example, measure the dimensions of the bronchial tree, or assess the thickness of the bronchial wall. That kind of measures are in the data. We are not really able at the moment to release them for interpretation. So would you agree on this, that we cannot really address COPD at the moment with the lung cancer screening? I think that's a very important issue, because in all the communication that we are doing with politicians, but also in the lay press, for example, we talk always about the COPD, but we are not measuring, in my view, COPD. So would you reflect on this?
Well, I largely agree with that comment. I think the challenge is how do you measure it? And I think with AI, there's the potential of measuring it, but it has to be standardized in some way, right? So one vendor can't be giving one answer and another vendor a different kind of measurement. You have to have something that's reproducible and people can follow over time, but we're not there yet.
Yeah, I think another point to make here is, well, quantification is clearly valuable for longitudinal assessment. There's also visual assessment, right? And so despite the fact that we probably don't have consistent enough CT protocols to achieve airway analysis quantitatively, there's still the opportunity to visually assess the airways in concert with emphysema to then direct further follow-up.
Yes, as you mentioned, politics and political decision-making, I would like to go one step back and remind us that currently in 99% of the world population, we don't have any screening programs, and political decisions to implement them are still pending. So the last thing we want to do is confuse political decision makers, and therefore I always propose a staggered approach. Yeah, we have excellent evidence for lung cancer screening, and that lung cancer screening lowers mortality of lung cancer. Yeah, this is better proven than for every other screening program, real-world evidence and everything. So this would be, for me, maybe lung cancer screening 1.0. This needs to be done. It should be implemented. The evidence is there. The proof that we can do is there. So we need lung cancer screening programs in all high-income countries and upper-middle-income countries. Then we can talk about, maybe we call it lung cancer screening 2.0, yeah, how to enhance, enlarge, improve lung cancer screening programs, get benefits for other diseases, and so on. And then we have one day maybe 3.0 with lab biomarkers with further improvements. And of course, it's very important to do the science on 2.0, 3.0 now, because we want results from the science, which means science has to happen now to have the results tomorrow. But we should always, I think, clearly divide the primary political aim to get a lung cancer screening started, to get it running, to implement it, yeah, from the scientific discussion how to improve lung cancer screening, enhance it, add it. Yeah, this is why I like this 1.0, 2.0, 3.0 scheme, yeah, to avoid confusing political decision makers with bringing too many things at once. Yeah, so I think it's absolutely valid to already now think about what is the next step, but not forgetting the first step. The first step is that we get I look at Witold, in Poland, in Germany, in Czech, everywhere, lung cancer screenings up and running for lung cancer. And then we can add the next steps. And in countries where we already have lung screening programs that run, like Croatia, like USA, we can already go to 2.0 because 1.0 is always made. I always propose this stage approach, yeah, starting stage 1, lung cancer, then stage 2, adding further disease, stage 3, next step, and so on.
Okay. I absolutely like the approach from Jim Mulshine. I think it's a fantastic idea to start collecting sequential data because you can add to the CT, the clinic, and all the other information, which will improve. There's no doubt about it. I don't think that with a scan, which currently is a screening test, we have to measure all the airways and all the details. The first question is, what do we want from this? And today, we have an underserved population, we heard that earlier. We identify the people, then we give them to the appropriate gold standard technology, and then if we get better over time, then we can change. And we are still having a big job ahead of us with lung cancer. We have an even bigger job to extend this to big free screening. Now, I completely agree with the politicians, you need to be careful, but from an implementation perspective, this is an ideal scenario for a learning healthcare system. Means in the operational execution, you generate the data from the scanners, from AI, and from the clinic, and you put it all together as standardized as possible, and that gives you the ability to improve over time faster and faster. And that's the huge opportunity we have here, given this public health challenge of so many premature deaths.
Yeah, so very mixed responses from my point of view. The first thing I would like to ask you then, if we dig into the calcium scoring itself, it's a very, in the eyes of many, a very validated measurement. You get a biomarker out, you can make decisions on it, it's there, and at the moment it is in many countries already obliged to report on it. So there's not really a way around it. So this phase 1, we do only implementation of lung cancer without reporting even on calcium. It's not possible. So this stepwise approach, which I like, of course, because of the systematic approach of the Germans, they are famous for this, it is not going to work outside of Germany, of course. So therefore, we report in the Netherlands on the calcium scoring, they do in the UK, they are going to do it in Germany. Whatever you want, it will happen. And it is already happening in all kinds of opportunistic screening centers. So how do we approach this? Should it be guidelines at the moment to do it or not to do it, or just make it a kind of additional information for the GP? Should they act on it? What should happen? So first, let's have the role.
You know, I think one of the striking things that Dr. Ranji pointed out is the vast majority of patients who enter a lung cancer screening program should already be on statins. And the critical decision from a calcium score is statin or not. It's not, are you going to do an angiogram or anything else based upon a calcium score? So I think it's a very curious observation that you have so many patients who already should be on statins, who have coronary calcium that we see, and aren't being treated for it.
That's a different situation. Huh? So that's
Well,
the US.
The question is, why report on it unless we're going to be able to change an outcome?
Okay, that's a question.
Yeah.
So,
Okay, for me, it seems like there's a lot of evidence in the literature, both for cardiovascular disease and the relationship to coronary artery calcium score, as well as COPD, that there's a benefit to early detection, there's a benefit to intervention to prevent exacerbations and prevent cardiovascular disease progression. So I don't see why these scores wouldn't be factored in at visual assessment at the very minimum to deciding how to proceed with the patient. But I am a humble medical physicist. One perception, though, I have is that it's a colossal waste of dose, honestly, to do all this screening and just 2 to 3% of detection of cancer, and there's all this other disease going on that's there to be managed and help prevent progression.
Yes, I like the British approach very much. Yeah, they have the concept to recommend actions, yeah, not simply report findings. Yeah, so in UK, what is usually reported is a recommendation to the primary care physician. if calcium score is high, they say calcium score is high, please consider prescribing a statin. Yeah, I think this is a very important concept to not provide numbers or findings, provide direct actions, because then you avoid confusing primary care, overloading primary care. I think this is key, that countries have good guidelines, like in UK, where they say if calcium is high, the participant gets a letter in easy language. We found, luckily, no lung cancer, but a certain cardiac risk. Please speak to your GP. And a simple, actionable recommendation to the GP, please assess clinical risk and, if necessary, prescribe a statin, period. Yeah, I think this is a very good concept to handle these things, simple, actionable actions.
Can I just make one comment on that? Based upon the most recent guidelines, it's not, if it's a high calcium score, is it a non-zero score? So anyone with a non-zero score should be treated. And so that would be the recommendation. It's a non-zero score, this patient should be on statins.
Okay, I really appreciate your view on the Germans, being German. From my experience in the clinic, the UK is leading this field. And to make this very simple, the one thing that I learned that makes a difference here is a treatment protocol. If we protocolize the treatment and we hand this out, not a guideline recommending a radiologist to report. They do this, we heard it. And then people are not comfortable doing the next step. We need protocols to follow that even for the junior doctors become their Bible. And in the UK, I learned this the other way around. Junior doctors follow the protocol, senior doctors may override it. And this is not the way we practice this kind of screening in most of the scenarios.
Thank you. They're all valid points. And clearly, we're going to be doing what you had talked about previously. This is the learning healthcare system. And I think people should, the National Academy of Sciences in the US has done a series of publications about systematic approaches to using evidence coming out of routine care to optimize innovation going forward. And that's what we're doing. And I think people could look at it because it creates a scaffold for developing all these different national approaches in a more systematic way, that they talk about the need to develop harmonization in terms of protocol, harmonization into reporting constructs, methodology, metrology. So that's all very important. And if we do that, we'll save a lot of wasted energy. That's one thing. But the second thing is, a lot of what we've been talking about will clarify as we get more mature screening data back. But the big problem here, which the people here are very aware of, is the fact that there's a collision now between visual inspection, which is the basis for most of our literature, and digital, quantitative data that going forward is going to be the foundation of AI, clinical management support, and whatnot. And the collision is kind of interesting because the NLST cases brilliantly were made available for others to use with the data sets and stuff like that. Great process. And we need more images and we need more clinical outcomes. However, those images were a part of a function of a study started in 2002 with 4 detector scanners with 2.5 millimeter slice thickness. And then you take that data and you train AI to look at small changes in 5 millimeter nodules. I mean, it's absurd. But we've got to take that basic approach and start thinking about where this is going to be 5 years, 10 years, what's going to be happening in terms of scrutiny for quantitation and stuff like that. So regardless of all the other chaos, if we can at least agree to minimal thresholds for quality standards so that we know that the substrate, the data, the imaging data, will be at least better than NLST quality in 2002, that would be very, very useful. And Sean and others are involved with the process that started through Kiba and is now continuing through other mechanisms. But if you do that, and the quality of the data is above a threshold, it will make for much more homogeneous results and much less time spent with experts discussing about how many angels fit on the head of a needle, and much more useful transactional information to rapidly optimize clinical management.
Is this a question to the panel or what?
No, I think
Okay.
think-
No.
suggestion.
Oh, it's a suggestion. Okay. Now, I think we still have to make some steps in the direction of terminology. So the big three are tobacco related. So we will not have any discussion on this. And then we have the incidental findings. I think it's very important also in the communication to separate those comorbidities from incidental findings. Would you agree? That is the question.
So I think one of the shared opportunities here is the value of the study.
It's about terminology.
No, if we're talking about the big three, instead of just lung cancer screening, we're changing the value equation for doing the study to begin with. And having that shift strengthens the argument for a screening program. And in that regard, I think it would make sense to not be entirely so tobacco focused and talk about the big four. And I'm referring,
And what is the big four then?
the big four would be
Osteoporosis,
osteoporosis, exactly right, which has tremendous,
which is not tobacco related.
No, it is. It is. There's excess
No, it's a question. You say yes.
well, but it's something that is measurable on these scans. You can follow it over time. And again, it shifts the value equation for doing the study. You're getting more information from the same radiation.
So you would say, in fact, all incidental findings at the end are tobacco related?
I don't regard this as an incidental finding. It's another screening.
You have the same problem with the aorta, of course, huh?
But this,
And
no,
the
this is-
calcifications
this is-
in the vascular system are all tobacco related. So in which direction are we going with terminology?
osteoporosis is underscreened.
And at the end, let's go.
And there's tremendous
along the
mortality and morbidity from it. And again, it's on these scans.
Okay.
And it readily can be measured with simple tools.
So circling back to emphysema, there's a lot of screening participants who have significant emphysema but no diagnosis of COPD, right? Is that an incidental finding? I think you have to decide where there's an actionable threshold. And if they exceed an actionable threshold, then it's something you need to treat. And below that, I guess, it could be considered
So
incidental.
you would say that's still experimental, cannot be implemented yet?
Well, yeah, I mean, visually, it's implemented, but to come up with an absolute threshold, we need to really work hard on standardizing and defining
Yeah,
the
you would
boundary.
agree on that, yeah. Bernard?
Doesn't it simply boil down to the prevalence in the screened population? So, I mean, we have certain diseases where the prevalence is above population average in the screened population, and we have certain diseases where the incidence is at population average. We had the discussion whether osteoporosis is more common in the screening population or not. Calcium is clearly here. And incidence in the screened population defines positive predictive value, and we can act if the positive predictive value is high enough to justify the action, prescribing a statin. Yeah? So I see more of a continuum. We have incidences in our screening population. This results in a positive and negative predictive value, and this triggers action. And I see more a continuum. You can discuss much more diseases, all have different predictive values in the population. Interstitial lung disease is another disease that commonly comes up in this population. Yeah, we have many more, but I see more a continuum, and we have to see disease by disease and see do we get a high enough positive predictive value to take action? And the core is
Okay,
action.
so the actionability is for you a very important
For me, it's
parameter
like this.
for further look at the implementation. I think that's a very important one, because that also reflects what we try to discuss here. That's the natural course of events, of course. And if that is not influenced by an intervention or by the knowledge of the diagnostics, then I think you should not do it. But that's for debate. So could you go further on this, Volkan?
Yes, I see two aspects, right? An incidental finding to me is something that I didn't expect. So the moment I start with a protocolized approach, the question is what is inside the protocol? And if it's ideal, there shouldn't be any incidental findings. Unless you get to the second point where we're talking about the quality and coming back to Dr. Mulshine, right? Garbage in, garbage out is always true. And I'm in the IVD world. If you don't collect your blood in a proper way, you don't get a result. If you don't do your scan in a proper way, you don't get a proper result. Then you get incident telomas, which are actually ghosts that later disappear. So it's absolutely essential to standardize as much as possible and then do, based on the evidence that we have, the best possible protocol there, and that will reduce your incidental findings as much as you can, which makes life easy for everybody who deals with the process.
So I think we make small steps so far. I would like to have a reaction of Louis Sayo. Is he here? Oh yeah. Could you give some reflections on what you heard so far, especially on the point of COPD and emphysema?
Right. So there's the issue of what are we diagnosing with low-dose CT, and I agree that it's mostly emphysema, and so and I completely agree that we have to quantify and we have to be actionable, so that burdening an asymptomatic individual who smokes or has smoked with 10 diagnoses, and they leave, they come in to get lung cancer screened, and then they come out thinking that they're going to die of 10 different things that they can't really put in any context. So actionable is very important, and thresholds. What is it that we are reporting, and is this clinically relevant to the individual? And then I would add to that we should not forget it's a teaching moment. So if we have somebody with emphysema, I do use emphysema, even if it's mild, to impress upon an active smoker how important it is that they should stop smoking. And I use that. Is that fair? I don't know. I don't want to scare them, but then again, they continue to smoke. If they don't smoke, then my take is different. And I am a big proponent of pulmonary function studies because I do think that they are more clinically relevant than mild emphysema detected on a CT scan. If you have even mild obstruction, that goes a long way down the path of getting to symptoms, right? So to me, performing lung function studies is really an important part of screening. I understand this is not common practice and that many would object to that for many reasons.
But would then be the first step that we can, to a high degree of certainty, make a distinction between normal and early detection of emphysema? Because if you have no clue about normality, because of the random noise clustering that is in emphysema detection, especially in lung cancer screening where you work with very low doses, the random noise clustering is an enormous problem. So you will get overdiagnosis of emphysema, and especially when you want to detect it early. The development of lung fibrosis is within reach now to stop it in an early stage. So that would mean that early detection of emphysema really means something. Then from your perspective, should then early detection make sense of emphysema? And then secondly, should it trigger further testing?
So I don't think that early detection of mild emphysema is clinically a priority. I'm not saying it's not important, but I don't think it's our priority, right? We're seeking to detect lung cancer. We're seeking to detect clinically relevant diseases for an individual who is allegedly asymptomatic and comes to us for screening. So to burden them with something that may, talk about overdiagnosis, right? If we find early emphysema, which has no clinical relevance to that individual, and we burden them with that knowledge, is that really doing them a service? I don't think so. So I do think we need to look for relevant disease, even if it's asymptomatic or just barely symptomatic, but that is relevant to their immediate or, short-term, medium-term future, rather than something that is going to burden them with anxiety and all of that, and may not really help in their clinical outcome.
So,
I had a comment, maybe a slightly different angle, but what if you have a coincidence of a nodule that is suspicious or not known to whether it's malignant or not in conjunction with mild emphysema? Does that change your, how frequently you're going to bring that person back?
Right, so cancer is more likely to appear in an area of emphysema. So if you see a nodule in an area that's emphysematous, then you make that nodule appear more suspicious. I do use emphysema, for example, to characterize risk. So I will take an individual who has a family history of lung cancer, for example, who is 48 and really worried about having lung cancer, but allegedly doesn't meet inclusion criteria, and I will get a baseline CT. And if they have centrilobular emphysema, in particular, not paraseptal emphysema, which I think has no relevance, but centrilobular emphysema, even if it's mild, I will say, okay, you probably should be in screening because your risk of lung cancer is just quadrupled, plus you have the family history, right? So I use it in that way, and certainly to try to get people to quit smoking when they're smoking. But I would try to avoid tagging too much along the LDCT. I understand that the Dutch have this impression that we should probably not report anything other than lung cancer in a lung cancer screening CT, and I get the motive behind that. Now, I'm not entirely on board with that, but I do think we have to find a sweet spot. We have to come to an agreement as to what is really relevant to that individual, not just obviously there on a CT scan.
I think there's a profound ascertainment bias here. We have looked at cardiovascular disease with physical activity extensively, and we found it to be profoundly impactful, rivals statin in terms of its benefits. We have no corresponding body of information for early pulmonary disease. Our ability to be aware of early emphysema largely exists because of the development of CT scans. And yet, there are a number of studies that show that it is not an innocent bystander. It is very important, especially in African Americans, especially in women, and that it is not something that, that's okay. And I think that the benefit of lung cancer screening is it's going to illuminate more about the natural history of early pulmonary disease. And, the crazy thing about this stuff is it's not independent. The risk of death in COPD and emphysema is vastly elevated for cardiovascular disease. And in cardiovascular disease, we routinely recommend increased physical activity, and we reinforce it. And yet, it's almost like, do we think emphysema is a vaccination from cardiovascular disease? It's not. As we develop more interventions, many of the lifestyle interventions are going to be subtle. Our ability to understand the benefit of those interventions is going to be difficult. So I think as we do this screening, we're going to learn more about what tobacco cessation really does, and it affects osteoporosis as well as the big three. And we've got to be open to this. And the recommendation of the U.S. Preventative Service Task Force in recommended against screening for COPD is based on survey information and PFTs. It's not based on CT at all. There's no body of information that they viewed was high enough quality to allow them to make any judgment. So I think we got to be very careful, because a lot of the chronic inflammation from a pathogenic perspective that drives cancer also drives emphysema and also drives cardiovascular disease. So these things that we're talking about, it's always a mixture of harms and benefits. And the interventions that we're talking about that are lifestyle predominantly have very low risk profiles. And so you can recommend physical activity, you can recommend smoking cessation, and the specter of overdiagnosis is not there because it's going to benefit the people in many ways. And a lot of what we consider progressive COPD emphysema relates to deconditioning and relates to the loss of scaffolding and the biomechanics of breathing that, you know, physical activity is going to benefit. So I think we have a new world in which we can look through a different prism in terms of interventions and pharmacologic and non-pharmacologic. And I think the higher bar has to be for the pharmacologic because of cost and potential for toxicities. But we now, with CT, can potentially start fleshing out the fact that we're going to see changes in the intercostal musculature related to physical activity and stuff like that. And as we get better with AI, we're going to be able to characterize these things more precisely, more quantitatively. So we're going to be able to look at health impact as well as disease impact. So I think trying to be careful not to exclude relatively benign, low-cost interventions that says to a person, you don't have to become a cripple because we've been talking about emphysema, but this is just kind of saying your lungs are getting a little wear and tear that looks more aggressive than some other people, and so you having a healthier diet, smoking cessation, physical activity and stuff like that, those things are things that we're trying to promote anyhow, and that just gives us another reason to pursue them.
So, is there anyone who wants to reflect on this long?
I would just say that
Thoughts?
the ability to quantify and look at the change in progression of emphysema, progression of these biomarkers with time is a very powerful opportunity, right? So if progression is rapid, then you know it's likely you should consider intervening. As an imager, and I'm biased in that regard, I think all of these PFTs are obviously well established clinically, but they're fairly backward looking in that the changes in PFTs tend to reflect fairly severe disease processes, whereas the imaging could potentially detect these changes much earlier and therefore help preserve function if you intervene earlier.
Yeah, but if you go in the direction, you go in the direction of annual screen for everyone, like we had chest CT in the times of chest X-ray in the times of tuberculosis.
And that's why I think the lung cancer screening is such a unique opportunity, because we're already screening these individuals who have a high risk profile, and we can start to characterize how early this other, comorbid diseases are detected, and then how the subtypes are progressing. So I think characterizing that process.
You would think that there is a hidden policy to come to total screening of the whole body.
Yeah, I don't know if I have ulterior motives there, but I mean,
Annually.
it would be a waste if we didn't take advantage of these other disease processes that we know are associated with the risk of lung cancer.
Yeah, okay, it's a little bit provocative, but I think if you go to, Professor Chen from Shanghai, you should tell something about the Chinese approach. There, people would come for annual checkup, including lung cancer screening, but I think this is more from the perspective of whole body screening from a company or another actor that wants his personnel checked up annually.
Yeah, generally say yes, but specifically, I always advise for high-risk population, yes. For non-treatment population, you don't have to yearly, maybe several years needed a check. For your company, it's very good, and higher pay or in their benefit very good, they will cover that CT screening.
Would you personally support the idea of an annual total checkup?
Because that not cost too much. This is why, the main reason. It cost too low.
So you're not against it? Okay.
A slightly different perspective here because we are talking about a high-risk population. So we're not talking about everybody. We're talking about smokers, tobacco use, and we've seen the big circles of the coronary calcium.
No, but in China, they
know,
don't
I know.
have this.
We haven't talked about
Okay.
biomarkers in the sense of before the scan at all, right? The UK is showing us that with the Liverpool risk model, they're doing the first steps to identify the right population. We are seeing genomics with polygenic risk scores emerging, and we are working on exactly those inflammation markers, which are the actual underlying risk. So back to your point, do we want to scan everybody? No. Do we want to screen everybody? Yes. Everybody who has a risk for developing cancer, but that's the challenge. And we can look at mammography, which is a lot broader today than lung cancer, but that's eventually what you want, is to cover that population that develops cancer. And the better you can characterize it before the scan, the better you can do the program.
But you are in the biomarker development stuff.
Yes.
So I would say, would you agree that such a biomarker should really have a performance that outperforms age as a risk biomarker?
I would say it should complement risk. If it outperforms is another question. What we want is to get a risk model using all the information that is there that gets as many or as high sensitivity with whatever specificity you can achieve. So if you find close to, let's say, 95% or more of cancers, and you can reduce the population by half with a specificity of 50%, that half would only have 5%. That's what we're after.
Yeah, and that makes it so interesting that we can indeed identify a population with calcium scoring, which have a 0 score that reflects through all diseases. And if you have any disease, even diabetes, and you have a 0 score, your risk that you have a survival different from a normal aging is getting lower and lower and lower. Mm-hmm. So the predictive value of a 0 calcium score is probably the best predictor so far, except for a real risk denominator like a very fast growing nodule. So we have to identify what we are doing more or less. So terminology matters, but also the way the actionability matters, I would say, but also the way we approach what we are going to report and what we are not going to report. So should you, and that's a question for you, for the whole panel, should you report on something that would not lead to actionability?
So very short, I would be with Jim Mulshine again. If we talk about smokers, there's always actionability. Stop smoking, start doing sports.
But then you don't have to do a test. You can just advise that.
Agreed. But then you have to make the study and show how much does it motivate to have one of these 10 diagnoses going out of the scan for people actually to pull through and do it versus coming back next year with another year of smoking.
It's a very, very expensive way to motivation, I would say, but okay.
I would like to remind that smoking cessation support is anyway part of any screening program. I don't know any organized screening programs globally that are not linked to smoking cessation support, and it works reasonably well within the limits of this highly addictive disease. Yes, smoking is a very strong addiction that is very difficult to cure, even with optimal support. Yeah, and scaring people did not provide very good results in smoking cessation.
We just reported on this. After several years, it goes back to the same percentage.
I think the question of what to report, I think we need clear guidelines on this. Yeah, also for legal clarity, physicians need to have a clear guideline they can rely on what to report and what not. And as said, I would recommend everyone to look at the UK. I think they have a very pragmatic model based on actionability. Yeah, and the actionability of a emphysema finding goes a bit to the pulmonologists in the room. Yeah, I see Louis nodding. Yeah, Maroline also gave her statement on this, and my perception from the pulmonologist's feedback so far is that the actionability of a medium emphysema is still an open question. Yeah, what do I do with this information? Yeah, and then it's the question: why should I report something that has no action then?
So the loss of not reporting is that you don't see it on follow-up either, or you don't notice that it's progressing. So that might be where computer-aided analysis could kind of save us here, right? In that you can always look at the change quantitatively from time point A to time point B, and then that can help inform or guide the interpretation.
And maybe one comment, now in Europe, everyone uses AI software anyway, and most AI tools on the market push out these results anyway. Yeah, so it's already there. Yeah, so this is.
But that would lead to guidelines on what are you going to report and what you're not going to report.
Yeah, I think this is needed.
That's very important.
Yes.
And if you bring in actionability as a guideline, that we know exactly from this point that you automatically get all the data on what they call emphysema, so the LAA percentages per lobe, and also as a whole and as a percentage of the lung. And it's very, very tempting to use it for a clinician. Very tempting to use it. And we know that it will increase with lower doses of the CT. The clinician doesn't know anything about the dose of the CT. So the data are even not interpretable. So it should then, if we follow that kind of guideline, not be possible to report on those parameters. So that will be we had an argument with the Dutch Health Council, and they said, okay, out of the evidence, you are able to report on the calcium score. So we can, for unknown reasons, report from 300 and higher, not 400, 300 and higher. And we are not able to report on the LAA. So we cannot report on the emphysema percentage or whatever you call it. So that is already a step in that direction, but that is what is already mentioned from a very reluctancy from the Dutch health policy makers of inducing more and more cost into healthcare without any actionability. So without any perspective that it is useful to do it.
This is where we have a challenge, because actionability in terms of pharmacological intervention, acceptable, but we know that cardiologists now are very focused on preventing the first heart attack. Because if you can prevent the first heart attack, it massively decreases the rates of congestive heart failure.
That's exactly what calcium score would not do.
No. Yes, yes, I thought it reduced MACE.
No. That's the key problem. There are many publications on the fact that that young patients will get a heart attack with 0 scores. So that's a real, that's the big key argument of many cardiologists, that you should not use the calcium score.
No, okay, but you have a collision there of a genetic disease versus an epigenetic disease. And when you mix the two, the interventions are different. We're talking about epigenetic type of disease in this screening set, especially in the smoking setting. Actionability in terms of preventing the first respiratory failure that we saw already, how important that is in changing the pace of a progression of respiratory consequences of COPD emphysema. Preventing that is actionable. And the actionable things already exist as recommendations in terms of vaccinations, in terms of certain amount of care about industrial exposures and stuff like that. They are actionable things that are currently ignored broadly. Compliance with them is very low. We've heard about the fact that when you get a CT and it shows emphysema, the people are more compliant to following up on recommendations and following up on sustaining the response to smoking cessation and stuff like that. It could be that actionability in terms of these other things would also be more compliant, would be more, faithfully followed, since there are already recommendations from, big national committees and stuff like that in the United States, from Health and Human Services recommends vaccination and this, and people over age 65, and not everybody follows up on it. If they get an emphysema diagnosis on a CT scan, there's preliminary observations that does improve those things. So I think we've got to look at this as a complex thing where over the next few years, given the data that we're going to capture, we're going to be able to make much more informed recommendations as to what actionable preventive measures can be applied and actually have an impact.
Okay, now a lot of comments. I would like to ask again to Louis Sayo what he would like to have as information from a lung cancer screening CT scan. What would he like to know and not know from that scan?
So I think the big three is a good start. You have patients come to clinic say, I have steatosis. That sounds horrible in my liver, right? And it's a common diagnosis and probably doesn't mean much for that patient other than he has to exercise and maybe change his diet and so on. So the big three is probably a good balance, meaning those diseases that really are going to have a major impact on that patient's outcome or that individual's outcomes. They're not patient if they're not sick. I think part of the problem is lung cancer screening is very different from other types of screening where you really need to sit down with a patient and explain what's on that medical report or that radiology report, right? It's not like a bedtime story, it's like a novel. And if they read it on their own, they're going to panic about everything that's in there, including benign stuff that just sounds terrible. So it's the sitting down with them that is at the same time an opportunity, but also a challenge, because I can see how politicians and administrators say, all right, this is a lot of information, it's just going to burden the system and the individuals with all this information, and nothing is actionable, or if it's actionable, we're going to incur in false positives and damage to those individuals. So if we stick to those big three that really have a tremendous impact on those individuals, I think it's a good start. By trying not to be nihilistic about the whole thing and just saying, let's just say cancer yes, cancer no, and we're done. I think we shouldn't do that.
Okay, same question to Paolo Raggi. Where is he? Oh, there's a question over here. Oh.
You have been discussing the incidental findings for a while, and also in terms of the management. So I just want to remind you that there is guidelines, at least European guidelines, endorsed by 6 major European societies regarding the management.
That is the second box of Pandora. So we are going to
I fully
publish
agree,
on
but
this
this is a start that we need to discuss, and I think this is very important.
It's a special session.
Super. Thank you.
Special session, extra session. So on this question, Paolo.
Are you asking whether I would like more than the big threes on the report, or which of the big threes I would like?
You get a lung cancer screening. You can also, of course, reflect on incidental findings, not particularly on this, because that's a special extra session to discuss it. But what would you like to come out as a report? You are a cardiologist. You get a patient that has just a lung cancer screening examination. What kind of information you would like to get from that examination as a cardiologist?
As usual, there are 2 considerations. One is a clinical, one is a research application or academic interest. So from the clinical point of view, besides the lung cancer, yes, no, or what type of cancer you detected, obviously the presence of coronary calcium to me is incredibly important. But there are many other pieces of information on that chest CT that may be of interest to me as an academician. Size of chambers, for example, or size and, if you will, even density or whatever you want to call it, attenuation or epicardial fat. That's another one. Osteoporosis, and Dr. Stillman already mentioned it. Steatosis in the dome of the liver. There are so many other academic questions that can be answered by a chest CT. Clinically, the two that I find the most useful from my point of view, obviously besides cancer, the presence of coronary calcium and the extent of it. That's what I would like to do.
Well, I think we're going to come back to many of these issues throughout the rest of the meeting. And I thank you. I thank all the discussants, the presenters, and appreciate that this is just one of the most remarkable healthcare issues that exists. And thank you all for a very exciting session.